Great. So I'm pleased to be introducing our next speaker. So our next speaker is Karen Strybos, ICU manager at Abbotsford Hospital Intensive Care Unit. She has been nursing since 1997 and been in critical care since 1999. I've worked closely with her. She was an educator, a PCC, a bedside nurse, and now manager. She's going to be sharing her presentation about family-centered critical care rounds.
Hello, everybody. I want to acknowledge the help that I've had from other people across the country. There's one particular person, Sherry Watts. She's a clinical educator at St. Paul's Hospital in Saskatchewan Health Authority, and she had a great deal of influence over how this all turned out. Of course, my team had a huge amount of involvement in how we rolled this out, including a patient partner that we engaged. So why make a change? What happened was I was looking at the feedback we were getting from our family satisfaction surveys. First of all, we weren't getting a lot of family satisfaction surveys back, but we're getting a number of them. And on those family satisfaction surveys, there was a lot of low scores on the satisfaction for the amount of times that people could. We had a consistently kind of low score on that question. And the other thing that was going on was that we had a lot of complaints in relation to a lack of information, maybe inconsistency, and the fact that we're getting information in a very spotty kind of way. So it was usually by family meeting only. There wasn't a bedside RN updates, but there wasn't a lot of team information being shared. There was also a literature search that we did, and the practice was very strongly supported in the literature, and we wanted to really improve our patient and family experience in the ICU, more of an open and trans environment. So we decided to embark on this. First of all, being in critical care for more than 17 years, there, of course, were some care team concerns, including on my part, and those were privacy and confidentiality was number one. When I spoke with others that have already kind of implemented this sort of a family-centered rounds, especially with Sherry, one thing that she said to me that was that, you know, don't give yourself a false reassurance that people are not actually hearing things when they're in the ICU. Of course, they're curious. If they see a code going on and they're visiting their loved one, they're going to look. They're going to be careful with that, not because they're trying to, you know, breach somebody's information or confidentiality, but just for the nature of the environment that they're in. And what we ask is we ask families, they overhear things about other people's family members, that they actually just keep that to themselves and not to share. They find that we have a lot of our families get to know other families in the family room outside the unit, and they're coming in the hospital. Family, to the patient says it is, oftentimes it's a friend or it's somebody that is maybe not a blood, and so we try to make sure that we identify family as whoever the patient would say it is, whether the patient is or whether the TM is telling them. And we give guidelines to families about the length and timing of rounds, because we want to make sure that our rounds are not extended a great deal because families are participating, and we wanted to make sure that it didn't turn into another form of a family meeting. So rounds have been kept to the same format, the same language, and the same timing we were before. None of that actually changed, and I'll kind of explain why a little bit. But those lines were very helpful in letting families know what rounds was all about and why it might be helpful to them. And then difficult families, I put my quotations because I'm assuming everybody kind of knows what I'm talking about. Sometimes we have families that need a lot of information and ask a lot of questions, and that's just something that they need. And it's not necessarily that they're difficult, it's just that they need that information. I feel like for myself, I might be a difficult family if somebody that I loved was in the ICU and I couldn't get the information that I felt I really needed. It's just another way of families. And I think that it's a lot more trusting. It's building a trusting relationship, and it's showing transparency and honesty with families. And I think that they are much more able to make really important care decisions and actually the direction of care decisions a lot sooner, and they feel good about the decisions that they're making because they've got the information that they need. The other thing that came up for why not were families' impression of the team. People were concerned that, questions or teaching rounds, as we all have, that families that were present might find that they felt that there was maybe some uncertainty or the team wasn't as knowledgeable or as skilled as they should be. But we've actually found the very opposite. When families witness the care together, they first of all notice that there's a lot of different interprofessionals that are working to care for their loved one, and they're also seeing just the way that everybody is working together as a team to support them. And that is the feedback that we've had. I had feedback at all about teaching, not having confidence because of questions and things asked in rounds. The language, so we were concerned, a lot of team members are concerned about having to change language in rounds, but quality rounds is something where we're going to share blood work results, we're going to look at, imaging results, we're going to be talking about complex medical terminology, and so the rounds, like I said, is not meant to turn into another family meeting. It is meant for the care team, and so we didn't change language or our terminology, but what we did make sure that there is a summary at the end, which is a kind of a high-level summary. It's about the plan of care, the direction of care, and any kind of like outstanding things that we need to still look at or outstanding questions. And in every single family feedback from family participation rounds, that was highlighted of how important that was for families to have that foundation. And then if you have any questions, in reality, what they do is they're just going to ask the care team. And so the care team will provide them with a summary or answer the question that they have. Okay, so this is the guideline that we give families. We just kind of describe what rounds is. We obviously recommend that the decision maker or the TSDM attends. And then the one difficulty is that it is visible, so people don't always know. It's not always 2 o'clock or 1 o'clock or whatever. And sometimes our rounds, especially on Monday, our docs change over in our unit. I don't know what your guys' units are like. Sometimes it takes a bit longer to get that done because the patients are new to the on-physician team. Rounds could occur pretty much at any time. But what we try to do is give them a heads up if they're very interested in attending. Maybe they've taken the day off work or they're trying to time their visit so that they can attend rounds. We try to give them a heads up by phone so that way they can show up within, an hour or two of actually happening. And we do communicate with the docs and say, the family's here, they'd like to attend rounds. We kind of work things around in that regard. And I just state in the guidelines that if they want more time to ask questions or speak, or they've got a more private conversation that we don't want to maybe discuss outside of a patient's room, we're going to get a family conference together, and we'll make a time that works for everyone for that. So this is the feedback form that we used to gather feedback from anybody that was participating. So that was from anybody on the care team, nursing, RTs, interprofessional team, so dietary, PT, everybody. And then we also gave this to families, and so we had a lot of family, we had a lot of team member feedback as well. So we had 25 feedback forms received from families, and we all had, of course, verbal feedback that was shared, not directly with me, but with nursing and team members. And then 25 feedback forms, same number, it's not a typo, from the stand. We did get feedback. We talked about this in staff meetings, and we also held several meetings specific to this initiative so that we could whatever needed to be changed or address any barriers having. And so the feedback was really quite positive. I didn't get any feedback forms received from physicians, but I did get some verbal and email feedback, and it was very positive. The only thing that was brought up was sometimes family do need more information. They may start, asking a lot of detailed questions at the end of rounds, and then they just need a gentle redirect that we're going to set up a family meeting. Sometimes the docs have a hard time saying that to them, though, because they really want to have that information in the moment. And then, as I said, our patient involved in reviewing the written feedback, and he was fantastic to give his perspective and asking those questions, why not, why can't we do this? So this This is just some feedback from the families, and it was actually quite thrilling to read what they had to say, and it was actually a little bit emotional too, because I think unless you've actually been a family member of somebody in ICU, or you've had an experience where maybe you didn't have the access or the openness between yourself and somebody who had a lot of information that you really need to know, I thought this was so impactful. There was a great feeling of inclusiveness, of not feeling an outsider, of feeling like the team was very transparent and honest, that they had great access to the team, that they could talk to the doctor, that they could witness the team doing the work together. And then the comments about what was being said and the language we used, basically, like, it didn't really matter that I didn't understand what was said. And there were also a lot of comments from families about being worried about what they were going to hear, but also knowing that they needed to hear it. They felt better hearing it from the whole team versus just hearing it from, maybe a bedside. So I just put a couple of pictures here of the actual forms and sort of what it looked like when they came back. Some people wrote very little, some wrote a lot. As you can see on the one on the left here, it says apprehensive of hearing bad news. But that person also said it says, please continue, it's a great policy. And then on the right-hand side there, I loved the part where this person's honest discussion of outcomes and probabilities, also gaining a better understanding of the system is functioning and the ways the staff look at individual parts and the whole working together. And I don't think that families get a lot of opportunity to witness that in reality in critical care. And this is something that's kind of broken down that barrier. With a family meeting, a formal family meeting, it's the physicians closely with the family members, and it's kind of choppy, right? Like if the patient is admitted on a Monday and you don't get another family meeting till a Thursday, a lot can change in critical care between a Monday and a Thursday. So this kind of just gives an example of how that more continuous feedback and even just the opportunity of being able to participate has a huge impact on the family. And then this right also said it's very comprehensive and thorough, which brings peace of mind for care my loved one is receiving. And then feedback team. So we were constantly gathering feedback and sort of making changes as we go along the way. There were some things like sometimes rounds were kind of long and family was quite exhausted. I mean, they're dealing with their loved one in critical care. So they might zone out. They might be struggling to live the whole round, even standing for the whole time. So we determined that we would just let families know, if you need to step away, you can head into the room if you want. We're not going to think that you're rude or anything like that, and we'll call you back when there's information if that's what you want. We have somebody on the team, no matter whoever is most aware of the family and maybe have a connection with them. We'll introduce them at the start of the room. They could bring a pen and paper if they want to write down some questions. Sometimes they get overwhelmed and they don't remember what they wanted to ask by the time the end comes up. Obviously, we want to make sure that we have the right teaming around, so it was usually CACCN and one other person. Sometimes we had more members involved, but it was the permission of the CACCN or the patient. And we talked about the timing of the rounds. This is a feedback form from a staff member, and just talking about the insight from that we get from the family. More to, obviously, knows the patient a lot more than we do, and we've gained a lot of good information from the family as well. Overall outcome, better transparency, much more trust between families and the care team. And I think that it is a great opportunity to show families the work that we do and how interprofessional we are, how much we rely on each other. I think one amazing thing about critical care, how much we do care as a team. And I think it's very, very impactful. And there has been a significant reduced need for family meetings, formal family meetings. That's been a very good impact on our physicians and for actually our whole team. I find that families are making much more clear on their direction of care sooner because they have the information and they're aware if it's getting better or if they're getting worse, or if they're not progressing in the way that we are trying to help them get to. So So that's been really amazing. And as I said before, families are sharing really important information. We've had families say to the team, you know what, my mom wouldn't want this. You know, I can see that, you know, she's not getting better, and she told me that she wouldn't continue on with this if there wasn't, you know, much hope for a meaningful recovery. So next steps, we're looking into creating an app you can access versus our many pamphlets. We've got scans of pieces of paper and pamphlets that we hand out to families, which can be overwhelming, and I don't know if a lot of them go into recycling or what, but I think having the year 2020 would be great. They also have an app at that Saskatchewan Health Authority Hospital, St. Paul's, that Sherry Watt works at, and so I looked at her app. Is fabulous, so I'm hoping we can get maybe some dollars to do that. And then we're beginning to move this practice acuity. We already had side rounds there with patients themselves. There are some other challenges doing this, so that we're working on those, and we'll gradually start creeping into. And then we're starting a critical care long-stay care planning rounds, and that's a week. We're going to start involving patients and their families where possible, but we still have a few more things to work on before we do that, including involving our patient partner. And then we want to get some more feedback on this from families and other things in ICU. So we're looking at real-time patient experience rolled out in ICU and high acuity, and that's done through volunteers on an iPad, so you can get some actual real-time and you can get some more detailed feedback, and you can tailor your questions to know. So thank you very much for allowing me this opportunity. I'm wondering if there's any.
All right. Well, thank you so much, Karen. That was awesome.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.